Our first speaker needs no introduction. It is Professor Kenneth David Boffard. Professor Boffard is the Trauma Director and Academic Head at Milpark Trauma Center, Johannesburg, South Africa, in University of Witwatersrand. Until January 2014, he was the Chief Specialist and Head of the Department of Surgery at Charlotte Maxike Johannesburg Academic Hospital, as well in South Africa. He is the Secretary General of the International Society of Surgeons in Zurich, Switzerland, and he holds the rank of Honorary Colonel in the South African Military Health Services, amongst many other past and present accolades. He will be giving a talk on penetrating war injuries, guns and bombs. Professor Boffard, please.
Hello to everyone. It's again a great privilege to be present at the Asia Trauma Collaboration meeting, and particularly this meeting, looking at aspects of injuries, particularly military injuries in a civilian environment. I have no conflicts of interest. Ballistics is the science of projectiles in motion. It actually comes from the Greek word meaning to throw. It's the study of a missile's dynamics as it travels through the barrel of a firearm, its trajectory through the air, and its final complicated effect after striking the target. And the same applies to blast injuries. Every missile has kinetic, that is potential energy, made up of the mass times the square of the velocity. This is the energy that the missile actually has. That's a little different from the energy, doesn't matter whether it's a fragment or whether it's a bullet, that it actually imparts to the tissue, both by direct laceration and by associated energy, including the shockwave. So we talk more about wounding energy, which takes the basis of potential energy and then looks at, usually the mass doesn't change very much, but if the projectile slows down, that's energy that's imparted to the tissues. And we'll see how this works and how it affects the way we treat patients who've been hit by bullets or blast. There are different sorts of guns. There are shotguns firing multiple projectiles, rifles, which can be single shot or semi-automatic, and handguns, pistols or revolvers. A pistol and an automatic rifle can fire a round of pretty much the same mass. So the only difference between the two is the projectile is traveling far faster in one than the other. So if we look at the amount of energy in a tissue, this is a tissue specimen hit by a 9mm bullet. You can see the bullet tumbling. The shock wave is relatively small and in fact is confined to the area. That's a little different from a rifle bullet where the damage is huge, and the rifle bullet as it goes through has a very massive shock wave. As you'll see, the bullet going through, look at the shock wave blowing apart that tissue from both sides, and that's a vacuum inside. So as the tissue collapses, it sucks all the foreign bodies outside into it. So that's the same massive bullet, but the higher the speed, the more the potential damage that can occur. So bullets come with different purposes. You can have the sort of standard metal jacket bullet. You can have things like a shot shell, things that are designed for the aviation industry where you really don't want the bullet to go through and kill the passenger behind if you're an air marshal. And bullets that are designed to impart the maximum amount of energy to whatever they hit. The shape of the bullet is designed that if it deforms more and forms a greater cross-sectional area, then the reality is it'll slow down more. And even with a rifle round, the rifle jacket is designed to do the same thing. Handguns can be different things to different people, so that with a handgun, they can be altered. That is a favored gangland weapon and can fire all 32 rounds in 0.75 of a second. It is also potentially becoming a more favored terrorist weapon, simply because it's easy to carry. Shotguns fire a number of small balls of different diameters and can cause a significant amount of damage. The balls are contained in a plastic wad, and one of the things that you should be aware of is that that plastic wad, shown on the right of your picture, both before and after firing, can enter tissue and in soft tissue cause a lot of damage. It is radiolucent. It will not show on X-rays. Therefore, all you can do is be aware of it if you see a hole that is somewhat bigger than the bullets themselves. The problem with shotguns, of course, there are multiple pellets. And with extremity wounds, always do a full X-ray of every single patient, because if you find one of those little balls somewhere where you weren't expecting it, that's probably because it's embolized and you've got a vascular injury as well. Beware of secondary fragments. When a bullet hits bone or any other hard tissue, the bone itself will break. This is a picture of a rifle round that has hit the bone. You can see many fragments of bone around, and you can also see parts of the bullet casing. So be aware, firstly, that there can be remote injury, and secondly, do not digitally probe these wounds because you may find your finger has been impaled on them. The second confusion, particularly in certain countries, is what is called urban armor. Obesity can certainly confuse the assessment, and you have penetrating injuries in a civilian population which look as if they're intra-abdominal, but may be well clear. And if you are in any doubt, it's worthwhile doing a CT scan to assess the bullet tract, because it may well have stayed well clear of the cavity itself. The effects of wounds are dependent both on the fragments and what hits them. So there are mechanical effects. A bullet can enter, break bones. It can hit the bones so that the bones become secondary fragments. And this particular patient was a bullet wound to the face, but most of the injury on the right-hand side of the face that you can see is simply the bullet hitting the maxilla and the zygoma, and those wounds are caused by the fragments of bone that came out. So what do you do when you're faced with any sort of wounds? Well, the first is be prepared to extend. Skin is healthy and takes a lot of punishment, so don't remove skin if it's at all necessary. If you've got a bullet hole, just trim the tags. Extend the incisions across a limb in the line of what you would do a fasciotomy. Do not do it transversely on the limb. Remove dead and contaminated tissue. We recommend for all bullet wounds and all penetrating wounds a bag of Ringer's lactate or saline and some IB drip tubing. Cut off the end of the drip tubing and use that, put the bag on the floor and stand on it if you wish, and use that to lavage the wound inside and out. And do not close penetrating wounds like this because they do drain, and it's better to have them draining out. Be aware that you need a very high index of suspicion, and crush syndrome or compartment syndrome is very common. Consider a fasciotomy. It's always easier to close a fasciotomy if you have a limb in which you can still close it. Monitor the possibility of muscle damage. Creatinine kinase and so on are very helpful adjuncts. These do swell up, and constricting bandages may make things worse. We do recommend, as does NATO, the use of antibiotics primarily because of the foreign tissue. Bullets are sterile, but of the foreign tissue that is sucked into the wound. Generally, in civilian use, augmentin clavulanate, amoxicillin clavulanate, or cefazolin are recommended. Remember that because of damage to cells, you should double the dose. So normal amoxicillin clavulanate is 1.2 grams IV 8-hourly, double it. Ditto cephalosporin derivatives. Should missiles be removed? No, not unless they're close to an important structure, vessel or nerve. And if there is functional damage, then they should probably be removed. Lead poisoning is a Hollywood issue. I'll fill you full of lead, but lead poisoning is not usually a problem. Do missiles travel in straight lines? Yes, they do, unless they hit bone or something like that. We recommend with all wounds, place a paper clip or other marker over where the skin wounds are. And then if you have a plain X-ray or even a CT scan, you can project the bullet's trajectory. We mentioned missile embolism. It implies vascular injury, and missile tracts should be washed out, and further damage for surgical reasons should be minimized. However, in zone 2 of the neck and in the abdomen, if you're not sure, exploration is worthwhile. A colleague of mine once said, a negative laparotomy is better than a positive post-mortem. There's a lot of truth in that. Let's talk a little bit about explosions in the urban environment using military weapons or improvised explosive devices. They're high-tech, they're cheap, they can be triggered with a cell phone or a garage remote, and they're indiscriminate in whom they injure. Weapons of mass destruction in slow motion include landmines, and unfortunately in the current conflict in Ukraine, it is alleged that landmines are being placed around bodies to try and capture extra victims. Blast injuries have 5 components to them, and we'll come back to these. But a blast, fragments, the body itself is thrown around, there are effects from the blast, and then there are quaternary effects. The primary blast injury is caused by the explosive, the direct effect of the blast. It is less lethal in open spaces. It is more lethal in contained areas. So therefore, in most urban bombings, unless it's in a room, a pub or something like that, their injuries are somewhat reduced. What happens is that the primary blast injury can itself cause problems, particularly in the ear with rupture of the drum, eye, rupture of the globe, respiratory system, and GI tract. Of all of these, the ear is the most sensitive. So when you have a patient that you talk to and they are not responsive, it may not be that there's anything wrong with their brain. It may actually be that the problem is that they cannot hear you. There's often ossicular injury as well. So all patients who've been involved in any sort of blast but have their ears thoroughly and carefully examined and their hearing checked. The globe commonly ruptures as well, and many patients wear contact lenses, so all eyes have got to be meticulously examined in any blast injury. The larynx, because of the blast of hot air, can get severely burnt. Respiratory system, the shock wave goes through the chest wall and causes significant local bleeding. On the right of your screen, this blast was on the patient's left-hand side, and you can see the pulmonary contusion that has occurred. Limbs are very visible, very overwhelming, devastating not just to the patient, but to the staff looking after them. Tourniquets have made a very big difference, not only in military, but in civilian aspects as well. One warning, all tourniquets come with that little white tag that you can see attached to them. That's there to write the time of application of the tourniquet, particularly when patients are being referred between hospitals. There's a danger that the patient may lose their limb, not from the injury, but from the length of time that the tourniquet has occluded the circulation. Secondary missiles are incredibly common. They can be primary from the coating or casing of the bomb. They can be secondary because there's a pressure wave with every bomb followed by a vacuum, and whatever else is in the area will be sucked into the close proximity of where the bomb was. And one sees this where buildings have blown up from the outside, but the glass, instead of being blown into the building, has been sucked out by the vacuum wave and falls on the victims below. Blast fragments can be gunshots, fragments, IEDs, And the picture on the bottom right was actually an individual who was in a pub, and those injuries were caused by the wooden walls of the pub being sucked in and all became missiles. Now, these are not shrapnel. Shrapnel was named after Major General Henry Shrapnel, who's initially conducted experiments on an artillery shell which blew lots of tiny balls. It was last used in the First World War, so we use the term shrapnel, but this is now metal fragments. The blast injury causes a lot of secondary damage. The problem is that that can be incredibly fast. Remember that these fragments can travel up to 1,000 meters, a kilometer per second. This picture is taken from Iraq, of Allied soldiers in Iraq who, perhaps through error of judgment, were looking at a deliberate explosion of an IED. 1.5 seconds later, they're all dead from those fragments. Do not be curious. It killed a cat. Wound contamination may be severe from whatever is there. The only treatment for this, anything that is there, must be washed, and washed again, is the only way to deal with it. Tertiary blast injury occurs when the victim is thrown against the ground or solid objects. Injuries are similar to blunt objects, but you can see this is an early Afghanistan picture. The crew are in an open vehicle. Once it goes bang, they're all thrown out, and most of their injuries and deaths were from this secondary impact, not from the blast. The body strikes surrounding objects. There are multiple fractures. They invariably end up with some skull fractures. And then, depending on where they are, there is hypothermia that goes with it. It is recommended that when someone's been in a blast, you should do a whole body CT scan. That at least will give you some idea of where those injuries have been. Quaternary blast injuries are from the heat, usually in confined spaces, invariably burns, and all of these components can happen at the same time. There's a worry about nowadays, even in a civilian environment, and again, it is being alleged in the Ukrainian conflict, that chemical agents and biological agents may be part of it. And there are still dirty bombs and fuel air explosives beyond the scope of this lecture, but they are devastatingly effective. So what do? Well, the initial management in the field is the emergency department care, emergency care by the victim or the victim's buddies. Very simple. The treatment of bleeding is to stop the bleeding. Deal with the airway simply if you can. Press on any direct bleeding. Use a pelvic binder. Use hemostatic agents if they're available. If there are fractures, splint them. If you are not close to a hospital and air evacuation is possible, consider air evacuation. In the hospital, the reality is you have an ATLS scenario. You must stop the bleeding. The bleeding treatment is to stop the bleeding. You should have massive transfusion protocols. You must aim for normothermia. Do not block up CT scans with multiple patients. Use the fastest thing you can, usually ultrasound. In the emergency department, the ATLS procedures, the treatment of bleeding is to stop the bleeding. And in penetrating injury, remember that bleeding is going on where you can't see it. We do tend to use early antibiotics in these patients, as we mentioned before. Listen to what has happened to the patient. What are the blast circumstances? It's primary survey. The caveats of CT are the numbers dependent. Always X-ray the chest as your first line in blast lung and abdominal ultrasound if nothing else is available or you do not have the time. And remember, always check hearing and vision. Surgically, damage control resuscitation. Do not use starches. Ideally, use blood and blood components early, and ideally use resuscitation-directed goals like serum lactate and thromboelastography. Do an early laparotomy. Do not try and save limbs and lose life as a result. Packing and binding for the pelvis rather than anything else. Fixation after you've done that. Remove necrotic tissue, but if you're not sure, leave it alone. You can always come back. Damage control surgery. Leave wounds open and wash them. Circulatory repair may require a shunt. Wide spectrum antibiotics, as we mentioned before, and fasciotomies. You can always close a fasciotomy unless the limb is not present because you didn't do one and amputation became necessary. A short word on damage control. That's the Titanic. It was the first ship which had the boilers all isolated, and you could see them at the front, so that if one was whole, the others would function. But it was poorly designed because the water filled in all four and the weight broke the ship in half. The film showed you the results. That differs from the USS Cole. Look at the man on the top of your right of your screen compared to the whole. But because damage control was properly done, the ship was being able to sail to port and subsequently moved on that Norwegian ship back for repair. She's still in service. Damage control is good. Damage control inappropriate is bad. Appropriately done is better. Antibiotics, staph, strep, clostridia, and coliforms. We recommend amoxicillin clavulanate or cefazolin for every single patient, but again, double the doses. So in summary, what have we learned? We've learned that you cannot ever deal with this unless you're a team. That damage control, resuscitation, and surgery is a religion that everyone should follow. Do not close the abdomen initially, but try and have it closed within the first week. Use a mesh-mediated closure only as definitive care. Bundle surgical site infection, adequate optimal analgesia early. And a lot of these patients, particularly if they have long-term injuries, become grossly obese. So later on, just watch out for their weight. But we've also learned thou shalt not ever have tension in closing. Thou shalt not ever not ask for help. When you have multiple patients, don't waste time and don't use meshes in the initial situation. Casualties do not arrive with labeled wounds. Casualties do not arrive with a sticker saying what they were shot with, who shot them, or where they were shot, or where the fragments are. Treat the wound, never treat the weapon. Thank you for your attention. Thank you to the organizers, yet again, for everything that you've done. I appreciate your time and enjoy this session. Thank you.